The pulse rate is 90 beats per minute, which is regular, low volume and of normal character. The blood pressure is 180 mm of mercury. JVP is not raised. There is no malar flush. On examination of the pericardium, there is visible cardiac impulse in mitral area. There is no scar. Apex beat is undisplaced, lies in the fifth intercostal space from the mid-clavicular line. It is tapping in character. There are no heaves or trills. On auscultation, the first heart sound is loud and second heart sound is normal. There is an opening snap in early diastole, which is followed by a low-pitched mid-diastolic rumbling murmur with pre-systolic accentuation at the apex. The murmur is best heard in expiration with the patient in left lateral position. Lung fields are clear to auscultation. There is no peripheral edema. There are no signs of the pulmonary hypertension. There is no stigmata of the infective endocarditis. The diagnosis is mitral stenosis. Case 2 presentation. The pulse rate is 110 beats per minute. It is irregular, low volume and of normal character. The blood pressure is 180 mm of mercury. The venous pressure is elevated. There is a malar flush. On examination of the pericardium, there is visible cardiac impulse in the mitral area. There is lateral thoracotomy scar. The apex beat is undisplaced and lies in the fifth intercostal space from the mid-clavicular line. It is tapping in character. Apical diastolic thrill is present in the left lateral position. There is presence of left parasternal heave and P2 is palpable in the left second intercostal space. On auscultation, the first heart sound is loud and pulmonary component of the second heart sound is also loud. There is an opening snap early in the diastolic, which is followed by low-pitched mid-diastolic rumbling murmur at the apex, best heard in the expiration with the patient in left lateral position. In addition, there is a pansystolic murmur at the left lower sternal edge, which is louder during the inspiration. In a short early diastolic murmur in the pulmonary area, also louder in the inspiration. On auscultation of the lung fields, there is a bilateral basal crepitations. Liver is palpable, soft and tender. There is peripheral edema. There is no stigmata of the infective endocarditis. The patient has previously mitral valvotomy and now has severe mitral stenosis and with signs of the pulmonary hypertension, pulmonary congestion and right-sided heart failure.